So I believe this session is recorded. So if anybody has to go, that is okay. I don't mind lecturing to an empty room. And so we're just going to do a quick slide review. Dr. Colas usually does these with me, but unfortunately he's on vacation this week. So, but Dr. Miller has kindly agreed to fill in with some of the muscle reviews. So I'm going to do everything except muscle. So this first question, I was just going to kind of walk you through some basic strategies, which you actually already all know already. So let's think about this question here. Okay. So if you don't know what we're looking at here, which often happened to me when I was in your shoes, I think it's helpful. Like when you take your boards, you're probably going to see things you've never seen before or things that you just don't recognize. And I think the most important part is to not stress out, because when you panic, then you lose all the other questions that come after that, right? So step one is to stay calm. Step two, I think it's helpful to always keep the normal in the back of your mind, right? So even if you have no idea what we're showing you here, if you remember what normal skin looks like, and then you can kind of work your way backwards, right? So here, this is our lesion. Let's look at this again. We've got maybe some hyperkeratosis comparatively. And then the striking thing to me are these cells down here. They look different than the cells in the normal skin, right? They just don't look the same. So they're atypical. You've got atypical cells, and then then you ask yourself, where are we? We're still limited to the epidermis, right? We're not in the dermis. So what is your differential? Atypical keratinocytes in the epidermis is, you're thinking squamous cell carcinoma in situ or actinic keratosis, right? And the way you tell those apart is based on how much of this thickness is involved. But let's go back to this question. Let's say you couldn't figure any of that out, okay? If all you recognize is this blue down here, and do you recognize that blue? Maybe you don't, but that's solar elastosis, right? That's the change that happens to collagen when someone's been out in the sun a lot. So if all you recognize is that this is sun-damaged skin, you can now rule out the 5-year-old and likely the 35-year-old, right? So this is probably somebody older who's been out in the sun a lot. So now I'm between B and D. What do you think D sounds like? A pearly papule with telangiectasia. Basal cell, and this does not look like a basal cell, right? So now we're kind of left with one option without necessarily knowing what this diagnosis is. This is an actinic keratosis, which, as you know, normally presents as sort of the sandpaper-like red lesion on the skin. But I was just using this as an example to walk you through the fact that you don't have to know everything in a question to be able to get it right? You can just reason your way through stuff. Okay, here is your first question. So we're going to do it like we normally do, except this time I don't have big case scenarios for you. So you'll get an age and sort of location, and we will talk about what you guys think it is. You can work in teams. So here is our first group with the pointer. Let's start with the X-ray here. Point to what looks abnormal to you. Okay, very good. So this is the gross pathology here. Oops. So the pointer that I gave you actually will move the slides back and forth. Okay, so let's go back to this. What looks wrong here?
It's flat and white.
Okay, good. So it is sort of white, and it kind of looks vaguely kind of wedge-shaped. Very good. And then this, you already pointed to the abnormality. Can you do it again, please? Excellent. And what is that, you think? Excellent. So this looks like osteonecrosis or avascular necrosis, right? It's got this beautiful kind of wedge of dead bone, and then there's this rim of normal vascularity that happens around it. And then if you were to do a biopsy, this is what you would see. So what is this, you guys? This is dead bone, right? And you know it's dead because up here is your normal for comparison. You can see we have osteocytes in normal bone. Here, this is all dead. It's just pink, and there are no nuclei. So this is avascular necrosis. Let's talk about things that cause avascular necrosis or predispose somebody to it. So our team here, any thoughts on predisposing risk factors?
Steroids, Gaucher,
Good.
trauma.
Excellent. And those, I would say, are the biggest ones you think are corticosteroids, and we don't really understand the mechanism by which that predisposes you to avascular necrosis, and then fractures or trauma, essentially anything that's disrupting your oxygen supply, right? And then let's think about complications. What do you think will happen to this patient? Osteoarthritis, very good, because you can have this bone collapsing, right? And then you don't get proper alignment of the femoral head and the joint, and you can get osteoarthritis secondarily. Very good. Any thoughts on this one? We're going to move on. Next case. And you guys can do this as a team. So what do you guys think this patient has?
Seborrheic keratosis.
Excellent. And I don't know if there's anything, well, I guess I could ask you, let's say this patient says these lesions came on over the past week. What would you be concerned about?
An internal malignancy.
Excellent. And usually it's an adenocarcinoma of the GI tract, so that was the lesser Charlotte sign, right? Very good. So kind of these waxy, stuck-on hyperkeratotic papules, and under the microscope you're seeing acanthosis, and then what are these? The H is a nice clue. These are horn cysts, right? Considered pretty characteristic under the microscope for seborrheic keratoses. So the cells are benign, and then this is just keratin, which gets trapped as the lesion grows. Any thoughts, comments? Okay, going to move on. Next group. What do you think this patient has?
We said enchondroma.
Excellent. And so this actually already points to the lesion here in the bone. How do you know this is not something malignant?
It's well circumscribed.
Excellent. So it's well circumscribed. And what is a malignant lesion that you know of that comes from cartilage?
Chondrosarcoma.
Perfect. And where do chondrosarcomas normally happen?
The epistasis.
Epiphysis?
Of that.
Okay, yes. And they usually, what age group are we thinking of?
30 to 60.
Yes, we're thinking older people. So very good. That was a whole bunch of questions, and I appreciate that you put up with me during that interrogation process. But yeah, that was very good. So yeah, so we're talking about differentiating benign from malignant tumors, right? So you know this is a cartilaginous tumor, and if you know the age and location for bone tumors, you can usually get the answer right without looking at anything else, right? So we haven't looked at a lot of tumors that happen in the fingers or in the toes. Enchondroma is one of them, which already gives you a good clue. And then Anton pointed out the fact that this is very well circumscribed. It's got a little bit of calcification in it, which can be pretty typical for cartilaginous tumors. And then this is showing you a very well circumscribed kind of gray-white lesion, which is also what cartilage looks like when you cut it. And then here you're seeing hyaline cartilage in a well-circumscribed nodule. So this would be an enchondroma, okay? Now, These are benign, as you guys know. If you left it untreated, and if it's somebody who has multiple enchondromas as part of a syndrome, then what are we worried about? Chondrosarcoma, there's a small, very small chance of transformation. Any thoughts? Okay, going to move on. Next case. Where's that pointer? Excellent. So let's start with the x-ray here. Can you point to what looks wrong to you on the x-ray? And actually, let's do this. Let's all point right here, because I never know where I'm looking. So, okay. Perfect. Excellent. And then you've got a gross path, so what's wrong there? And the gross image. Perfect. And then you've got a microscopic image. And actually everything in that microscopic image is abnormal, so excellent. So putting all of this together, what does this patient have? Excellent. So she said chondrosarcoma, which is absolutely correct. So just going with the age, right? It's an older patient rather than a younger patient. And then the location, remember chondrosarcomas normally happen in axial skeleton, right? So we're thinking like ribs, spine, maybe pelvis, shoulder, right? That's kind of where we're thinking of chondrosarcoma happening. The x-ray is relatively characteristic in terms of this sort of, these little flecks of calcification is something you see in cartilaginous tumors. And then this is a pretty well-differentiated chondrosarcoma. That's why it hasn't yet invaded through the cortex, but it can. It can invade through the cortex into the soft tissue. And then remember what we looked at in the enchondroma, right? It's the same color, this beautiful kind of white-gray color on cut section tells you that this is a cartilaginous tumor. And you see how there are like multiple pieces. This is not a well-circumscribed lesion. This is an infiltrated lesion in the bone. So that tells us it's malignant. And then here, again, we're seeing cartilage, which is infiltrating into these bony trabeculae, which also tells you we're in a malignant lesion. Any thoughts on this one? Okay. Next case. So our team with the pointer. What looks wrong to you in this clinical image? Excellent. So how would you describe those skin lesions?
Maybe like a red papule.
Perfect. Excellent. So you've got red papules, and then maybe, I don't know if you can see this, but there are some blood vessels in here, right? So papules with telangiectasia. Excellent. And then you biopsy one of these, and it shows you this. And here's a higher power view of that. So what is this?
I was thinking possibly basal cell just because of telangiectasias and then the palisading basal cells.
Excellent, and you're absolutely right. So this is a basal cell carcinoma. It's got these big blue islands of cells down in the dermis. And if you looked at this on higher power, you can see palisading, as you correctly point out. You can have some clefting between the tumor and the stroma. But this is a very characteristic look, right? There are no other skin tumors that look like this. So the fact that this is a young person and he has multiple of these and he has this thing in the jaw, right? What do you think this patient may have?
XP.
Xeroderma pigmentosum is actually a very good thought because it is an inherited condition that predisposes you to basal cells.
Could also be Gorl's.
Gorlins? Yes, excellent. So that was the answer I was going for, mainly because this patient has a whole bunch of basal cells, is young, and Gorlin syndrome is associated with some other abnormalities as well. Most of them are skeletal abnormalities. This is an odontogenic keratocyst. I do not expect you to know that, but you should know that patients with this this is the nevoid basal cell carcinoma syndrome, right? This is that, what's the gene that's abnormal? Patch, right? We remember that these people are born with a germline mutation in patch, and then the other one gets inactivated when they're out in the sun. And what's a good treatment option, you think, for this patient? Excellent. I heard vismodegib, which is a smoothened sort of inhibitor, which inhibits that pathway. So very good. Any comments, questions? Okay. Next team.
We're thinking gout.
Very good. And so you have, very good. I mean, you have all the classic signs and symptoms here, right? So what's this showing you here?
The podogra.
Yes, so you've got inflammation here of the first, the metatarsophalangeal joint, classic. And then what are these things?
Tophi.
Perfect. Deposition of uric acid. And so you really didn't even need the path, but if you did the path, this is what you would see. What do you think this stuff is? This is a higher power view.
The uric acid crystals.
Yeah, very good. So these are the uric acid crystals in here. And the reason it looks like this kind of fibrillary and smushed is because this got put in formalin and the uric acid dissolved. So this is kind of what it looks like when you look at it under the microscope. But these cells, these are all giant cells and histiocytes that are reacting to this stuff. So if you were to biopsy one of these things, this is what it would look like under the microscope. And I guess we can let's talk about pathogenesis of gout. So what causes usually, if it's idiopathic gout, what is the pathogenesis for the hyperuricemia?
Under excretion of uric acid.
Excellent, that's perfect. And I was actually thinking about this last night. I don't think I clarified this in class, but Robbins, for whatever reason, says the opposite. You know, it says it's underproduction, but that's wrong. Okay, so one instance where Robbins was wrong, and I didn't point it out. But anyway, so yes, so primary idiopathic gout, we're thinking under excretion of uric acid causing hyperuricemia. Some of those deposit right in the joints and around the joints, and they're eaten up by the macrophages and the neutrophils, and they release enzymes and cytokines, and it causes sort of damage to the cartilage. Okay, and then you guys already know about the treatment, right? How do you treat somebody with gout?
You could do allopurinol.
Okay, you could. And so it sort of depends on whether we're talking about an acute case of gout, right, or if you're talking about a chronic case of gout. Because if you give somebody allopurinol and they're acutely inflamed, what will happen? You're going to precipitate more attacks acutely, right? So you want to calm down that acute episode and then use some of those other drugs to decrease uric acid. Very good. And I think okay, great. So we have two pictures. What do you think this is? What type of crystal?
The monosodium uric acid.
Excellent, perfect. So if this is the direction of polarized light, then these are needle-shaped, negatively birefringent crystals characteristic of gout. What about the stuff in the bottom here?
Pseudogout.
Perfect. So CPPD crystals, which are rhomboidal, and they can be weakly positively birefringent. Any comments, questions? Okay. Next case. So let's start here with this CT scan. What looks abnormal to you here? Oh, okay, great. Thank you. So yes, you've got a mass here, and then you biopsy this mass, and it looks like this. Okay. And all of that is abnormal. What do you think this lesion is? This structure here is a higher power view of one of these cells. And it's okay if you don't know. Do you think it's benign or do you think it's malignant?
It's malignant.
Malignant, excellent.
We were thinking rhabdomyosarcoma.
Okay, so it is a sarcoma because it is malignant, and that's very good. Let's think about who gets rhabdomyosarcoma usually. What age group of patients?
Oh, they're too old. Never mind.
Usually it's younger
people.
kids, right? So what's the most common type of sarcoma that happens in older people?
Like a liposarcoma?
Very good, excellent, and that's what this is, okay? So, and you kind of reasoned your way through that, so that was very good. You can see that we have this big mass, and it's deep, right? Because it's right next to the bone, and we talked about the fact that when tumors happen deep, they're more likely to be malignant than if they're subcutaneous, right? So, and then this is a very characteristic image. It's showing you kind of bluish stuff in the background, and when pathologists see bluish stuff, we call it myxoid, right? So this is a myxoid matrix, and then you've got these vessels. These are capillary vessels. They may be branching, okay? And then you've got these little cells, which these are adipocytes, which are not maturing properly. So this is a lipoblast here, right? You've got a crazy-looking nucleus and lots of little lipid vacuoles in here. Anyone in the class, what type of liposarcoma is this? It's a myxoid liposarcoma, very good. And what is the characteristic translocation that you would see in this patient?
12-16.
Very
Yellow
good. So
chop.
12-16 translocation, and the abnormality is in that FUS CHOP or DDIT3, which arrests adipocyte maturation, right? So there are 3 types of liposarcoma. What are the other 2 types? Well-differentiated and pleomorphic. And the well-differentiated one looks a little different because it looks like normal fat, and then you get those hyperchromatic cells in between, right? And what's the genetic abnormality in that one? Did I hear MDM2, amplification of MDM2, which inhibits P53, which leads to tumor progression? Good. Any thoughts, comments on this one? Okay. Next case. All right, so let's start with the clinical image. How would you guys describe that?
Like a raised, almost ulcerated, crusty, like papule.
Yeah, very good. A papule or a nodule, whatever you want to call it. It's raised. It's got a central plug of something. Very good. And then this is what the micro looks like. Okay, this is a higher power view from around here. So what do you think this is?
Because those kind of look like buildup of like keratin.
Very good. There is keratin in there, all the pink stuff.
So
Very good.
maybe actinic keratosis.
Okay.
Or-
So that's a thought. Now, what do actinic keratoses look like clinically? They look like those little red kind of flat spots, right? You kind of have to feel them. They're kind of sandpapery, rough spots. This is a nodule, right? And then it's kind of like a crater where you've got this thing going down into the dermis. And then it's filled with keratin. This is a beautiful correlation, I think, between the path and the clinical, right? Because this is this. The keratin is what you're seeing in the center of this cup. And then on the outside, it's squamous. So you're right, it is squamous cells. But these cells are invading into the dermis. Okay, they're very well differentiated. So do you want to modify your diagnosis?
Perhaps more of a squamous cell carcinoma.
Excellent, and you're absolutely right. This is a squamous cell carcinoma. It's a well-differentiated type of squamous cell carcinoma. If I told you that the history is that this patient was fine and then a week ago noticed this thing come on, okay, does that ring any bells? Maybe it makes you think of a keratoacanthoma, okay, which is a type of a well-differentiated squamous cell carcinoma that comes on rapidly. And In the past, we used to differentiate these mainly because a lot of these lesions go away on their own, so if you left this patient untreated, it may regress. But now, if you go in to see a dermatologist with this thing, they will take it out because they are a well-differentiated form of squamous cells. Some of them may not regress, and you don't want to just watch your patient until something bad happens. So we take it out. Okay. Any questions on this one? All right. Next case. You guys are doing so well. Is this exciting? You could be pathologists. Okay. Next. What do you guys, what looks wrong to you on the clinical picture?
All right, so we see some larger joints, and you can see sort of an ulnar deviation of the fingers.
Excellent. And where are those larger joints? What joints are they?
The MCP.
Perfect. So just without even looking at the path, what is that?
I'm thinking rheumatoid arthritis.
Excellent. So this is rheumatoid arthritis. And then can you walk us through the path?
So we're going to see like hyperplasia of the synovium. So
Good.
you're going to get like a pannus, which will like bridge between the two joints.
Excellent.
Bridge the joints together and you get ankylosing.
Excellent, and that's absolutely correct. And I put this in here because I feel like sometimes there's some confusion between the rheumatoid nodule that you see in rheumatoid arthritis and then the findings that you see in the joint in rheumatoid arthritis, right? Those are two different things. So rheumatoid nodules, I mean, these are actually potentially rheumatoid nodules, these little things that are kind of subcutaneous. And if you biopsied one of these, you would see this finding. Okay, you've got fibrin in the middle and then a palisade of histiocytes. So what do we call a collection of histiocytes? A granuloma. So we've got sort of a granuloma with fibrinoid necrosis. This is a rheumatoid nodule, which you can see in the skin, you can see it in the lungs, you can see it in other organs. But if you were to look at the joints, then as our team correctly pointed out there, you're going to see this, which is your pannus, right? You've got synovial hyperplasia. It almost forms these villi. And then you're going to have lots of lymphocytes in there, which are all your blue cells. You may even form follicles. Remember that the process is started by CD4 T cells, which then activate your B cells. You get antibodies. It's an autoimmune process. You don't need me to walk you through the rest of that. So if you had to test this patient, what would be a very specific antibody for her disease?
The anti-CCPs.
Excellent. What about rheumatoid factor?
That's specific.
Very good. So very sensitive, but not specific. You can see it in other conditions. Remember, that's usually an IgM antibody directed against the FC portions of their own IgG, right? And then I'm not going to go into treatment, but you guys should know the treatment for these conditions. Okay, any other thoughts, questions, comments? We're going to move on. You can see that I conveniently skip over the treatment a lot, and that's because I'm a pathologist and I haven't treated a patient in a long time, and I like it that way. Okay, so next team. So how would you describe the clinical lesion there?
It's like a flat lesion. I don't remember what the term is.
Okay.
Is it patch? Is that right? Or
Okay, good. Yeah, so the flat lesions were macules and patches. The macule was small, the patch was a little bigger, and then the raised lesions were papules and plaques, right? So this it's a little hard sometimes when you get like a two-dimensional image, you can't feel it. It sort of looks flat. It may be a little raised in the center. It was supposed to be raised, okay? So it's a pigmented, slightly raised lesion. And then you do a biopsy of this thing, and you see this. And this is a higher power view of the dermal portion of this lesion. So what is your diagnosis, team? Okay, let's start with what category of lesions are we in? Is this a rash or is this a tumor?
More of like a tumor, like a nevus type.
Very good, excellent, excellent. So it is a nevus, it's a melanocytic lesion, and you're seeing these melanocytes, they're up here at the junction, right, in the epidermis, and they're down in the dermis, right? And then if you look at this on higher power, you can see that the cells are bigger up here, and they get smaller at the bottom. What do we call that?
A compound nevus.
Very good. Excellent. This is a compound melanocytic nevus. It's showing you maturation. If you start with the clinical, you use your ABCDs. This is beautifully circumscribed, uniformly pigmented. It's going to be small. I didn't give you the size. It looks benign, right? And then the microscopic appearance correlates with that. Very good. Compound melanocytic nevus. Questions? Yes.
In the top right image,
This
where
one?
it kind of looks like there's like an ulceration. Why is that? Why do we see that?
Is this what we're talking about up here? Yeah, so this is the keratin, which is kind of filling this area. This is probably going to end up being a hair follicle potentially if you did a deeper cut. Okay, so this is not an ulcer. An ulcer equals no epidermis. Okay? Any other thoughts? So if we had that same patient, right, a 55-year-old, I don't know what I told you on the face, could be really anywhere on the body, and if her lesion looked like this and like this under the microscope, where is our next team? Okay, how would you describe her clinical lesion now?
So this would be like a pigmented macule?
Excellent, excellent. And what does it show you under the microscope?
So you see like nests of melanocytes at the junction of the epidermis and dermis, so it'd be a junctional nevus.
Perfect, excellent. So it's flat and pigmented, which is what junctional nevi look like, and then you absolutely pointed out the findings. I have nothing else to add there. Any questions? Yes.
So I'm just a little confused looking at the epidermis. It looks like it just keeps going. I'm used to seeing when we're looking up top that it kind of ends. Yeah,
Yes.
It's like up there. What is going on there?
Yes, that's an excellent question. So what you have going on here is the fact that this came from a different part of the body than most of the skin lesions. This is an acral specimen. And by that I mean it came from the palm or the sole or something. And that's why the keratin is so thick. Okay, this is normal keratin. And you see this thing here? This is a stratum lucidum. In normal skin from other parts of the body, you don't see it. But you see that if you were to biopsy palm or sole. So that's what's going on up here. Any other thoughts? Okay. So you're probably sick of seeing this patient, but let's say she has this type of lesion now. How would you describe the clinical and the path?
A non-pigmented papule?
Excellent. Wonderful. And what do you see on path?
The melanocyte nests are only in the dermis, so it'd be an intradermal nevus.
Perfect. And that's absolutely right. So bland nests of melanocytes, they are maturing in terms of the pigment is mainly at the top and it kind of disappears at the bottom. Cells are bigger at the top, smaller at the bottom. You won't see mitosis if you look at this. This is a benign mole, a dermal mole. Very good. This is the last time you'll see this particular patient, okay? So let's say she has this lesion. Who has the pointer? So we're talking about this particular lesion here. How would you describe this, team?
It It looks like a flat macule pigmented.
Very good. And you biopsy it, and it looks like this.
So it might be lentigo because it's the melanocyte hyperplasia.
Excellent, and you're absolutely right. So you see how like some of these things do need to be biopsied because the pigmented things can look kind of scary. I think Dr. Trevino showed you some pictures of lentigo maligna type melanoma, right? I mean, this doesn't look that bad, but sometimes lentigos can look like lentigo maligna melanoma. So we do a biopsy to make sure we're not missing something really bad. And then as you very nicely pointed out under the biopsy, you can see that these redi are long, right? They're long and thin, and they can have increased melanin pigment in them, which is what makes it look pigmented here. And then you don't have nests of melanocytes. That's how you're telling a lentigo apart from a nevus. No nests of melanocytes in the lentigo, right? Very good. Questions, comments? Okay. Next team. So I think we can all see what's wrong clinically. You do the path. What do you think this patient has?
We're thinking maybe rhabdomyosarcoma.
Excellent. And you're absolutely right. So how did you get there? How did you get to rhabdomyosarcoma?
The age.
Good. And that's really, I mean, it's a key characteristic. That you look at the age, look at the location, almost always you'll get these things right. I mean, if you're thinking, this is obviously malignant, right? I hope nobody would say this is benign. You can see a big ulcerating thing, and then these look like small round blue cells. They have very little cytoplasm, and they're organized in this really gorgeous pattern where they're kind of hugging the fibrous septae, and then they're falling apart in the center, right? It's supposed, looks like a pomegranate, okay? This thing, you mean, the clinical? Yeah. It just looks gross to me, but yeah, I agree. So under the microscope, you've got these nests that are falling apart, and that's characteristic of what type of rhabdo?
Alveolar.
Alveolar, wonderful. So alveolar rhabdo, and what is the characteristic translocation? It's the PAX3 or the PAX7 with the fork head region, right? And the reason I'm hammering some of these home to you is because the diagnosis of sarcomas is evolving, but we often use these translocations to make the diagnosis. And sometimes, you know, the way you treat these things is different depending on the diagnosis. So anyway, so we know there's embryonal, there's alveolar, and then there's pleomorphic rhabdomyosarcomas. Of those, embryonal and alveolar are the ones that happen in kids. And the embryonal, we've looked at the botryoid type like a million times, so hopefully you guys remember what that looks like, the cluster of grapes. Okay, that's all I can think of for alveolar rhabdo. Any thoughts, comments? I suppose the other thing you could think of would be like a Ewing sarcoma, because that's also a small round blue cell tumor. But Ewing sarcoma almost always will start in the bone and then invade outwards, and it doesn't normally fall apart like this is doing, okay? All right, this is sort of difficult. Not that the others were not difficult, but, okay, who has the pointer? So can you pinpoint anything here that you recognize?
Maybe I see some osteoid here.
Okay, good. You see bone there.
Bone,
Good.
yeah.
Good. And so it's lined by these cells. What kind of cells do we think those are?
Are those like osteo, the osteoblasts?
Very good. Excellent. So these are the cells forming the bone. So you've got like bony trabeculae lined by osteoblasts. And then you've got, what do you think these structures are? So they're empty spaces, and they're often lined by a flattened layer of endothelial cells.
Oh, so maybe like vessels?
Good. So you've got vessels here, you've got some fibrosis, you've got this bone, and honestly, you're probably never going to see this picture again. But if I showed you this, I think you would know what I'm showing you. What is this?
Fracture.
Very good. So this is a healing fracture site. And the reason this was taken out, and this is actually from a patient in Dayton, is because this didn't heal appropriately. It was possibly infected. It was non-union. So that's a fracture callus. Remember, osteoblasts have like one single nucleus, right? And osteoclasts are the ones that are multinucleated. But this is fracture healing and repair. And hopefully you all remember the different parameters you need for appropriate healing. Okay, question?
This prompted my memory with Dr. Binsky's lecture. He went through quite a bit on trauma. What would you like us to emphasize when we're reviewing that for the exam?
Yes, so I tried to post a list of objectives, and that is my view of what is most important from his talk. I would say I really want you guys to know how fractures heal, the characteristics, the factors that are important for that. And then he talked about certain traumatic conditions. I think it's helpful to know about those. So I'm hoping that learning objectives will guide you in the right direction. Any other thoughts? Okay. Next case. Okay, so I guess we're back to this team here. Here, I can take that. Perfect, thank you. Okay, team, so X-ray. What looks wrong? Wonderful, it's very nicely demarcated for you. So do you think that's benign or malignant? Very good. And then you do a biopsy of this thing, and it looks like this. What is this?
Osteoid-osteoma.
Wonderful. Osteoid-osteoma is the correct answer. This is a benign tumor. It's got this really nice dark center, right? We call that the nidus of the tumor, and then it has the sclerosis around it, which is what happens when tumors grow slowly. There's time for sclerosis to happen around it. And then this is just showing you woven bone, and then it will be limbed by osteoblasts. Again, you'll have some blood vessels and some fibrosis in between, but this is a tumor as opposed to a fracture callus, okay? So osteoid-osteoma, remember the classic clinical? It's going to present with usually nocturnal pain in a young person right around the knee, and it's because of prostaglandins that are formed by the tumor, right? So it responds to NSAIDs. And there was another tumor which is very similar to this. It looks the same under the microscope. Osteoblastoma was the answer there, and that's usually bigger than 2 centimeters. This usually happens on the spine, right? Good. Comments? What do you have to know about osteoid-osteoma? Yeah, I think if you know the classic clinical presentation and you can tell that it's a benign lesion, I'm pretty happy with that. Yeah. Any other thoughts? Okay. Here's your next case. So let's start with the x-ray. I love that all these x-rays have nice arrows pointing out the abnormality. It'll tell you on the test that will not be the case. Okay, so who has that pointer? What do you guys think is happening radiographically there? Uh-huh. Yes, it is absolutely the Codman's triangle. And so you're seeing a tumor that's bursting through here, right? And then what is that? What forms the Codman's triangle? He said lifting up of the periosteum with sort of calcification or ossification, and that's absolutely true. And then you really didn't need this, did you? But now you have it, so what is it? Osteosarcoma. Very good. Excellent. So this is osteoid, right? This is the immature bone. Then you've got malignant looking cells. If you ever see like pink stuff that's kind of lacy, and then you see atypical cells, that's an osteosarcoma. We remember osteosarcomas are the most common primary bone tumors, and then they usually happen in young people, right? There's a second incidence in older people. And if an older person gets an osteosarcoma, what kind of risk factors are we thinking of? Paget's disease, excellent. Maybe radiation. Sometimes bone necrosis that's been there for a long time can predispose you to getting osteosarcoma. Good, that's all I can think of. Any other questions? So remember, young people, primary bone tumors, we're thinking Ewing sarcoma, or we're thinking osteosarcoma, right? Old people, primary bone tumors, what are you thinking? Chondrosarcoma? I guess that's really the big one if it's primary. Otherwise, you're thinking like MET or lymphoma. Good. Giant cell tumors can happen actually in younger people or in sort of middle-aged people, but it looks benign as opposed to like this. Good. Here's our next case. What does this patient have?
We're thinking maybe Paget's because we're seeing frontal bossing.
Excellent. So the skull is way too big, and you wouldn't normally biopsy this, but let's say this is at autopsy, and we're looking at the skull. What is the abnormality here in the bone?
There's too much bone being laid down.
Very good. So remember the stages of Paget's. Can you walk us through the stages?
So there is the sclerotic stage, the mixed stage, and the lytic stage. Those
Good, but reverse those. So we start with the lytic stage, and then
sclerotic.
Perfect. So those are the three. It progresses, and then if you were to do serologic testing in this patient, what do you think you'd see?
Increased levels of alkaline phosphatase.
Excellent, and usually normal serum calcium and phosphorus, right? And then the characteristic finding here are these lines. These are cement lines, which are annealing those newly formed bone fragments together. Okay, this is in the sclerotic phase of Paget's. So let's talk about complications of Paget's.
So you would maybe see cranial nerve deficits?
Good, absolutely. So as the bone is growing, it can compress on cranial nerves. They can get sensory neural deafness, right? What else? Very good. And it's not very common. It's like 1% of patients with Paget's can get osteosarcoma, but that's what we worry about, right? That's something we're concerned about. Sometimes you can get like bowing of the skeleton, which can then, like the femoral head gets disrupted from the socket, and so you can get secondary osteoarthritis. And then the other thing you can get, you have all these blood vessels here, right? You see all these big channels with blood. Mm-hmm. What do you think will happen if this person has this disease all over the body?
So you get high output heart failure?
Perfect. So high output cardiac failure, and we put a little note on Pilot about the mechanisms behind that. Good. So Paget's, think axial skull, older patient, right? Like we're thinking skull, spine, pelvis. Yes?
What's the difference between Paget's disease and osteopetrosis?
Very excellent question. So the other name for Paget disease is osteitis deformans, which I guess it can kind of sound like one of the other osteo diseases. Osteopetrosis usually is a disease of younger people. It's an inherited condition. Paget's is almost always acquired. It happens in older people. Osteopetrosis is the classic radiographic sign is that kind of flaring, kind of the radius and the ulna, right? At the tips, it looks like an Erlenmeyer flask. And osteopetrosis is the defect of osteoclasts, where the osteoclast cannot resorb bone, so it's very sclerotic. It looks really white on x-rays. You get too much bone, it kind of fills up the marrow space, and then you can get aplastic anemia as a result of that. Yeah?
Would you still get like the bottom looking picture, like the map like picture, or would it
Oh.
look different?
That's a good question. So normally, you don't necessarily get the cement lines in osteopetrosis. What you get is thickened bony trabeculae, and you will lose the marrow in the middle. But I wouldn't expect you to differentiate osteopetrosis from Paget's based on histology. I would expect that more of a clinical syndrome, like young people with an inherited condition versus older person with an acquired disease. Yeah? Any other thoughts? Okay. Oh, this was, I don't know why this was, okay. Anyway, you've seen this before. This is a thickening of the skull and then kind of lytic and sclerotic areas. Excellent. Back to the skin. Who has that pointer? What do you see clinically, team? Yes, you see the lesion, and how would you describe it?
Like a pigmented macule that maybe looks like a little bit waxy.
Okay, good. So you've got a pigmented spot, and you biopsy it, and it shows you this. What is this showing you?
The top part's the dermis, or the epidermis, and then the dermis, like where the clicker is on, is like the dermal epidermal junction, and then.
Very good. So you're looking at a biopsy of skin, and can you point out in this picture what is abnormal? Let's go back. Okay.
So there's like the nests of melanocytes in the dermis, and then there's like the pagetoid spread.
Excellent.
Melanoma.
So what's your diagnosis?
Malignant melanoma.
Perfect. So you're absolutely right. You can see these melanocytes that are percolating up. So we have pagetoid spread. These are big, ugly cells. They are infiltrating down, right? Remember, if you only have atypical cells limited to the epidermis, what do we call that? In situ melanoma, right? Once those cells have invaded into the basement membrane, now we're in malignant melanoma. These cells are not maturing. They're just as big at the top as they are at the bottom. And what are these structures? These are mitotic figures. And whenever you see mitoses in the dermal component of a melanocytic lesion, we should be very worried that that's a melanoma. Okay? Any thoughts, comments? Oh, what's the most important prognostic parameter? Yes, so you had a whole TBL, Breslow. Very good. Okay. Next case.
See like a osteochondroma type thing coming off the knee.
Wonderful. You didn't need us to walk you through this. Very good. So here's the mushroom, and you cut it, and it has a cartilage cap. And then this is what it looks like under the scope, and that is an osteochondroma. Wonderful. I mean, you guys remember there are some syndromes where people get too many of these. They have certain diseases in which it predisposes them to getting chondrosarcoma out of these. But in general, these are completely benign, right? Okay. Any questions on this? Yes.
Are those open epiphyseal plates on the X-ray?
And yes, I think you do have open epiphyseal plates in this X-ray, and therefore this should not have been a 30-year-old. This should have been a younger person. Thank you. Dr. Vanderberg would be so proud. Yes. I will fix this. Okay. Okay, well, there you go. Okay. Another question?
Does that projection interfere with muscle movement and contraction?
Well, I mean, it can certainly compress on the muscles, and it usually will present as a mass. If it's small, then it will probably not even be symptomatic, and you may just pick it up incidentally. It doesn't, I mean, it certainly compresses on the muscle and some of the nerves. It can cause pain. But I'm not sure if it would necessarily directly inhibit muscle contraction. Any other thoughts? Okay. Oh, that was it. Well, thank you. And Dr. Miller will share some thoughts on muscle with you.
Oh, no, you're good.
Okay.
Yeah, no,
Good.
no, I appreciate it. Just got to copy it on there. Hi, guys. All right, who's got it? Ben, all right. All right, sorry for the awkward delay here. All right, Ben. You knew I would start with this one.
We were thinking B,
B as in boy?
myocarditis,
Good. Yeah. So what is this?
the trichinella spiralis.
Yeah, good. So yeah, the most common cause of death in these patients is myocarditis. So they can actually get all of these things, really not septic shock that often, but they certainly can get myocarditis. Encephalitis occurs in these patients as well, though typically it's less common and they'll often recover from it. Pneumonitis, actually a few different things can involve their lungs. Either it can get into the respiratory muscles so they can have respiratory failure, or the larvae can migrate into the lung and cause a pneumonitis. How would you treat it?
Do we treat it with praziquantel?
So most time you'll treat with albendazole is probably, so this is a nematode. And then of course be aware of the eosinophilia. This one's famously associated with eosinophilia. But it's almost a buzzword now for these types of infections. But you may see that. And then what do they eat? Say bear. They might have eaten bear. One of these guys that slaughters a bear and then eats it in the wild. Yeah. Or pork, although they're pretty good at, if you cook the pork, you'll kill it. That's about all I got on this one. Of course, I had to start with it. Any questions on trichinella? All right, next. Who has it? Put it this way. I think to be fair, I'll give you another stain here. Have you guys read it and everything? Okay. All right, can you point out what might be abnormal in this biopsy? It's a little advanced. Do it again. Okay. So I think those are, what do you think those are? Here, so I think you're pointing to this stuff, which is probably just compressed nuclei of the muscles, but kind of look like lymphocytes. But then what about these guys right in the middle of the muscle? So I'll give you another stain, because that's primarily how you're going to see it. So if you do a trichrome stain, you'll see these guys. Any ideas what the diagnosis might be? Anyone? Yeah. Inclusion body myositis here. All right, so knowing that, what do you think the answer might be? So these are these rimmed vacuoles here. And they can have a number of other things in there, like ubiquitin inclusions and stuff. All right, this is like dinner at my in-laws' house, so I'm just gonna tell you. Like no one's saying anything, you're all just looking at me. Like, anyway, all right, I'll just walk you through it. So the answer here is D. So inclusion body myositis is usually grouped in with the inflammatory myopathies, but it's not really clear exactly what's going on, and most people would probably think that it's actually a degenerative myopathy that then has secondary inflammation. And part of the reason for that is that these patients usually don't respond to steroids. So they will often give them steroids because they don't have much else that they can do for them, and then they'll gauge how they respond. So if they if they respond, then they'll keep them on. And actually, they'll not just try prednisone, sometimes they'll try azathioprine, some of the other ones. If they do respond, then they'll leave them on. If they don't respond to the immunosuppression, they take them off because then it's not worth the risk. So accordingly, these patients don't have the best of prognosis because they're a little bit harder to respond to. So with A, sorry, Jenna, do you have a question?
I was just wondering if you could talk about E, because I know Robin said they don't get dysphagia compared to polymyositis, so the esophageal muscles.
Oh, I'll have to look. I thought they did get, let's see. I might be able to pull it up. I thought they did get it. Let's see. I will look. Yeah, it's listed as not uncommon. So they can get esophageal thing. I used to hate it when it would say not uncommon, but it kind of makes sense. It's not like a zebra, but it's not common. So they can get esophageal muscle involvement as well. What else was I going to say about this one? So this one usually in patients over 50. That's the path appearance. It's usually slowly. So, the other thing is that this is kind of a classic thing too. So it likes to involve, so a lot of these involve proximal muscles, right? So getting out of chairs, going upstairs, things like that. This one tends to involve the quadriceps most commonly, as well as distal upper extremities, so particularly finger flexion. So that's kind of a clue too that you're not necessarily dealing with something like polymyositis too, just in the clinical history. And polymyositis tends to be a little bit faster in slightly younger patients, but you can't really hang your head on it. So anti-MI2 associated with some of the skin findings in dermatomyositis, increased risk of ovarian cancer that can occur in dermatomyositis mostly. ILD, usually the other ones. Any questions on that one? All right, next. Who has it?
Okay, so we were kind of thinking between A and C.
A and what?
A and C, and we're leaning towards C.
Okay. So do you know which one this is? What diagnosis? That's okay. Or a differential.
Sort of muscular.
We don't remember the name of it, but like we remember like people getting tired when they're like washing their hair and things like that, like a lot of proximal weakness. And
Okay, so something with proximal weakness. Good. So yeah, because he's had, what's he having? Out of chairs, working above his head. Yeah. Has an elevated CK, right? And what we're seeing here, and these muscle biopsies tend to be somewhat advanced, but where the arrows are highlighting are basically this perifascicular atrophy, right? And then down here, can you recognize this being a small little vessel? And a bunch of little black dots around it, so mononuclear inflammatory, so lymphocytes primarily going around the, basically going after the capillaries or small vessels there. So this is dermatomyositis, and obviously I withheld the skin findings. So the pathogenesis of this is not 100% clear, but it seems to be two main things: an interferon, type 1 interferon, so alpha beta response, as well as some autoantibodies. So D is probably what I would go with, CD4, because they're CD4 helper cells, and also some of these plasmacytoid dendritic cells that stand for CD4, as well as CD20, which will get the B cells, tend to be involved there. So there's three main, I mean, the classic antibody we would talk about was the anti-Jo1, which is in like 30% of patients with dermatomyositis and polymyositis. They're also talking about the MI2 as well, the anti-P155 and I think 140 can be elevated in these patients as well. Dermatomyositis is at increased risk for adenocarcinomas of the ovary, cervix, bladder, things like that. Jen?
So is there something else in the histopath that can help us differentiate between polymyositis and dermatomyositis if you don't give us the skin findings?
Yes. So there are different skin findings, or sorry, biopsy findings. So this is classic for dermatomyositis. And then this, we can just jump ahead, is polymyositis. So with those, the lymphocytes actually get right into the endomysium, right? So they are going after the muscle themselves. So you can see some degenerating fibers here, some little black dots maybe attacking there, right in the center. And these are CD8 positive cytotoxic T cells. So if you're seeing the black dots within the muscle itself, that's more likely to be polymyositis. If you're seeing them around the vessels at the periphery, then it's more likely dermatomyositis.
So can you explain the path between for the CD20? Because we only learned it was CD4 only.
So so you'll primarily see CD4, but you'll also see the plasma cells in the site as well. So usually people are going to talk about the CD4s because that's typically what you're going to see are the small black dots being the CD4s.
And as Dr. Miller was saying, so dermatomyositis, the picture here is showing you that there's vascular involvement. That's something else that I use to differentiate dermatomyositis from polymyositis.
Yep.
One has more vascular involvement than the other. And then, as he was also pointing out to you, the CD4 cells, you know that they're helper T cells, so they're going to activate B cells, which is why you also have B cells.
Which speaks to the autoantibodies as well. And this little like white space there is the vessel, and then you get the lymphocytes just surrounding it there. So in muscle, involving the vessel, and then the perifascicular atrophy there. All right, anything else on that one?
Okay, are you ready?
Oh, I'm ready, Megan Smith.
So we're thinking the diagnosis is Duchenne's muscular dystrophy.
Excellent.
And knowing that the most common causes of death in that condition are respiratory and heart failure, we were leaning towards E.
Okay. All right. So what do you see in the biopsy? What's abnormal?
We got some atrophy.
You got some atrophy. Okay. All right. What are these guys?
Lymphocytes?
So these are, see how they're kind of like bluer, so basophilic. So these are probably regenerating myocytes there. And then we have increased, see all this increased pink stuff? So that's fibrosis. We have variation a little bit in the fiber sizes. So those are some of the typical findings in Duchenne biopsies, and it'll change with time, and I'll show you some more pictures of it. And I like your thought process. So this is related to the dystrophin gene mutation, and these patients, Duchenne's, have an essential absence of it. So it's also found in cardiac muscle and CNS. So cardiac muscle is a big deal, as you said, because of one of the reasons these patients die is cardiomyopathy or from arrhythmias. And then it's also in CNS, which explains why some of the patients, I think it's like 20% of them have an IQ less than 70. So not all of them. I had a friend in high school who had this, and he was, completely very intelligent. So it's not all patients. So you're right. So lungs can be, these patients can die from pulmonary respiratory failure, right? So that can be from a number of things, or pneumonia. They often get pneumonia. And part of the reasons it can involve the muscles supporting their breathing. So they can't just have respiratory failure from that. And then they also are at risk from pneumonia. And why is that? It's because you're not, and this is a big thing in surgery too, when they're laying down, or any illness where you're laying down, if you're not expanding your lungs can start to collapse. And then that predisposes you to have, not like collapsed lung, like in a trauma, like atelectasis. Have you guys heard of this? A little bit? Okay. So if the alveoli are kind of scrunching together, that predisposes you to getting pneumonia. So they're not taking deep breaths. They're not expanding their lungs. That's why they get pneumonia. Any questions on this one? Let me show you some. So just a refresher on the mechanism here. So it's involving dystrophin, which is connecting actin to the beta dystroglycan, which is part of that DGC. So the main reason they think these cells are dying is they get, when the myocyte contracts, it causes little tears in the membrane, allows calcium influx, and then the cell will die. So this is another example. So we have huge size variation, and these patients will have hypertrophic right next to either dying or atrophic. The hypertrophic obviously trying to compensate. These are actually becoming necrotic. You can see how they're kind of really light pink. They often get fat replacement as well. You can see just huge size variation there. Any questions there? All right. Next.
So looking at the history, we see that she has problems with contraction and relaxing when she does retract, or relaxing when she does contract, so you're thinking myotonic dystrophy?
Yeah, perfect. So it's kind of a classic history for it. This is actually a true case from one of the ED docs that was here in Dayton. And that was her first thing. She was having trouble with the blade, lifting and intubating patients and then she was noticing also she was having trouble with the jars. So that happened, and then she came to talk to us, I think, in our MSI class or ICM. So yeah, this is kind of classic for myotonic dystrophy. And on the biopsy, there's not much to see really, except you see all these. First thing is you don't see any inflammation, right? You see some of these black dots within the myocytes themselves, but those are the nuclei. So it's not necessarily specific for this. All right, and what gene is implicated here?
DMPK or something?
Perfect. Yeah, dystrophy protein kinase. So this is one of these CTG repeats disorders as well. There's a few different types of this, but you're getting kind of specialized. DM1 is usually younger patients and more severe. DM2 is later onset and less severe. Yeah, so think about this when you think of an adult with distal extremity weakness. Also, facial weakness tends to be a big thing. They often have temporal wasting, and they have a particular face appearance after a long period of time that has kind of a mean descriptive name. I forget what they call it. I think hatchet face or something like that. These patients also will get, what else might she be at risk for getting? What other symptoms might she have?
Cataracts?
Yeah, good. Cataracts. Anything else?
Cardiomyopathy, apparently?
Yeah. Cardiomyopathy. What else? Endocrine. Good. So usually that's often it's going to be hypogonadism in these patients. That's about all I can think with that one.
Dr. Miller, did you say that this, because she's 42, so would this still be the earlier onset one? Or could it be the...
I'm not 100% sure. I would probably say it would probably be more likely DM2 because she's a little bit older than most things. And often the DM1 do come on earlier than that and would have other manifestations. Right now she just has some of the muscle manifestations. All right, any questions? All right, guys, that is all I have on the myopathies. I'll stick around if you have any questions.
Let's thank Dr. Miller for filling in.